Good evening, everyone. Can you hear me? Can you hear me? Good evening, everyone. Just making sure you can hear me and see the screen okay. Evening. Good evening. Welcome. Autumn, welcome. Genesis, welcome. Melissa, welcome. Peacock, welcome. Vicky, welcome. Nikki, welcome. We're going to do opportunistic infections today. Anyone else hear me? Welcome, everyone, to opportunistic infections. I am ChicagoDLSinc. That's Chicago Diverse Learning Services. I do one-on-one tutoring for the Naplex as well as group sessions. Feel free to reach out if you need any extra help or want any guidance if you have a score report or a practice test that you've taken and want me to give you some guidance on that. Suspicious welcome. This will be a shorter presentation, but I do have three practice questions today to make up for it. And as always, please hold your questions until the end, and I'd be happy to answer any that you may have. So, can everyone see the background slide? Good. So, um, opportunistic infections happen to immunocompromised patients, and this can be to primary or secondary causes. Primary being that there's a congenital defect in your immune system, and secondary can be due to systemic infections. These opportunistic infections can be caused by bacteria, viruses, protozoa, or fungi. HIV is a major cause where the CD4 T lymphocyte count is below 200 cells per millimeter cubed. Now, systemic steroids can also cause this, especially prednisone if taken 14 days or more, 20 milligrams per day or more, or 2 mgs per kgs per day or more. Next, we have asplenia. And can anyone tell me what asplenia is in the chat? Good. Very good. So all three of you are correct. No spleen, without spleen, or a non-functioning spleen. So I actually have a practice question, not today, that talks about something called functional asplenia. where due to sickle cell disease, the spleen itself is there in your body. However, it is not functioning due to the damage from all of the clots. I'd like to draw your attention to the picture on the right, and the arrows that I've driven are the arrows that I've drawn are sickle cells. And so some of them look like the crescent moon shape or sickles. And then there's some that just look compressed, maybe like misshapen hamburger patties. And so all of these are sickle cells. And these patients, I know this is not that chapter, but just know that sickle cell is an extremely painful disease. You essentially have clots everywhere in your body, and it is extremely painful. If you're ever working in the hospital, please make sure your patient has sufficient pain coverage. Now, uh, immunosuppressants for autoimmune conditions or post-transplant patients can also cause um, the immune system to be compromised. And then chemotherapy agents, especially those that can cause neutropenia. Can anyone tell me what ANC stands for? And so if the ANC is below 500 cells per millimeter cubed, you'll have a similar problem. Just waiting for the responses for ANC. Good. Very good. So the absolute neutrophil count, there is a formula for this, and know that you can be tested on it. I've seen it in the pre-NABP. I've seen it in the RX prep practice questions. Um, and it's important to know this. Good. Good job, everyone. So our next slide says primary prophylaxis in HIV. Just want to plug another one of the admins. Suspicious Bunch has a really, really great guide for HIV. I've mentioned this before in other mini lessons. Do make sure you review it before your test. I think they've also uploaded some slideshows that they've done, and it's phenomenal. Uh, I took inspiration from them to add pictures and make mine more colorful as well. So thank you, Suspicious Bunch, for that. Now, what we're going to talk about are the three big ones for HIV. I was working with the past probably two or three students that I've worked with have all mentioned that in the Naplex, they do have questions about CD4 uh, count and what the cutoffs are 200, 150. So, first we have PJP, pneumocystic. I've heard Hirovecchi and Girovecchi pneumonia. It was formerly known as PCP. And this it happens when your CD4 count is below 200. And the preferred regimen is daily Bactrim double strength or single strength until the CD4 cell count rises above 200 with ART, and or it's 1 to 200 and there's an undetectable viral load for over 3 months. Now that over 3 months applies to the undetectable viral load or the CD4 cell count above 200. Can anyone tell me what the generic is for Bactrim? Hmm, hmm, very good. Vicky with the fast fingers typed the whole thing out. Great job. As well as Art. Good job, everyone. So we have here, the next one is toxoplasma. I've heard Gandhi as well as Gandhi. I've probably mentioned one in every presentation and every session that I work with. We are lucky we're not being tested on pronunciation. We just need to know what they do. So this causes encephalitis. I've also heard encephalitis when the CD4 count is below 100. And the preferred treatment for this is daily Bactrim double strength with similar guidelines to PJP. You want the CD4 count to come above 200 with ART, or you 100 to 200 with undetectable viral load. And the period needs to be 3 consecutive months or more. Alternatives for PJP or T. gondii, dapsone, atovaquone, or a combination of three: dapsone, pyrimethamine, and leucovorin, or atovaquone, pyrimethamine, and leucovorin. All of these, I don't know if I mentioned, my sources are RxPrep and Past Naplex Now, and I tried to incorporate the bold, got some really good feedback from the first session, and I hope that you see this as well. There are third line or third line combinations, but we're just going to focus on preferred or the alternatives that are underlined or bolded. Uh, if you look to the right, that is a brain scan, specifically a CT, and that is toxoplasmosis, neurotoxoplasmosis. And it is not fun. And um, I hope that if you become an HIV pharmacist or a hospital pharmacist, that you, when you come across a patient like this, you treat them well and improve their quality of life, and hopefully help them understand why art is so important. Next, we have MAC, Mycobacterium avium complex. This occurs when the CD4 count is below 50. You always need to rule out active disseminated disease. And the preferred treatment here is going to be azithromycin 1200 milligrams weekly. And alternatives are splitting that azithromycin into 2 doses of 600 milligrams each, or clarithromycin 500 milligrams BID. Once you can stop these medications once the ART regimen is on board and the viral load is fully suppressed. Can anyone tell me a brand name for clarithromycin? All right, great job. Starting to see some responses. All right, very good. Biaxin, yes. There's also Biaxin XL. Good. All right. Next, we'll go to the next slide, treatment of other OIs. So, other opportunistic infections that we'll talk about are candidiasis, cryptococcal meningitis, CMV, and a couple more. Just know that with some of these, after you complete initial treatment, sometimes you need secondary prophylaxis to prevent recurrence. And the secondary prophylaxis can be short term and it can also be long term. So on the right side, this is a picture of thrush. Also, oh, dang, I messed up. That's what was next to candidiasis, the AKA. My apologies. Thrush is another name for this condition, and it is a whitish film in the mouth and the throat. Preferred treatment for this is fluconazole, and when, oh, I see a typo, I'll fix that. With HIV patients specifically, or immunocompromised patients specifically, we prefer systemic treatment. So if you're not immunocompromised and you present with oral thrush, you can do localized treatments. Um, can anyone tell me the different forms of oral treatments for thrush or candidiasis? There's a couple key ones. Good. Good. I see Troche. I see mouthwash. Yes, good. Good. Is there a lozenge? Does anybody know? So Shinsalo, good. So, continuing, we have the preferred is fluconazole and alternatives for candidiasis. If it's oral, we can do itraconazole or posaconazole. And for esophageal candidiasis, you can do voriconazole or an echinocandin. Can anyone name an echinocandin for me? Bonus points if you can recall the mechanism of action. All right, very good, Vicky. Caspofungin. So that is candidiasis. I put these pictures, one on the top picture you can see is quite involved, and the bottom picture you just see patches, but you also see this redness in between the two white spots, the big white spots, as well. So that is candidiasis. Next, we have cryptococcal meningitis. Preferred treatment for this is going to be amphotericin B and flucytosine. Alternatives are fluconazole and flucytosine or amphotericin B and fluconazole. Uh, I believe there are two current forms of amphotericin B. Can anyone share what they are? And when I say forms, I mean specifically the formulation. Okay, so I have liposomal. Anyone else? Liposomal is correct. Good job, Vicky. I believe the other form or the original form is deoxycholate. Good. Good, Art. So, continuing, we have secondary prophylaxis for cryptococcal meningitis is going to be low dose fluconazole. For CMV, which is cytomegalovirus, the preferred treatment is going to be valganciclovir or ganciclovir. Alternatives can be foscarnet or cidofovir. Secondary prophylaxis for CMV, there is none. We try to maintain the CD4 count above 100. Next, we have aspergillosis. This is a systemic fungal infection. It likes to form cavitary lesions, and the preferred treatment for aspergillosis is voriconazole or amphotericin B. Last but not least, it is a fun word to pronounce, coccidioidomycosis. And if you set it as your Wi-Fi password, I will stick to using my data. Thank you very much. The preferred treatment for this is going to be fluconazole, itraconazole, or amphotericin B. All right, so that's all I have in terms of learning, and we'll start with the first practice question. If you're new, Sapphire, welcome. Autumn, welcome. What I do is I'll read the question to give you time to also read and process. And once I'm done reading, you can put your answers into the chat. Michaela, welcome. And and then we'll discuss and break down this question. And after we're done with that, if you have questions or concerns, we can discuss that as well. And just to remind you, because the lesson was so short for opportunistic infections, I do have three different practice questions. So let us begin. JH is a 60-year-old man who is seen in clinic for follow-up after initial testing confirmed positive for HIV infection. His HIV RNA is 1.5 million copies per milliliter, and the CD4 T cell count is 90 cells per millimeter cubed. He has no documented opportunistic infections and no resistant mutations. HLA-B 5701 is negative, no known drug allergies, and a creatinine clearance of 80 ml per minute. Which of the following prophylaxis regimens are required? Choice A, trimethoprim sulfamethoxazole. Choice B, rifampin. Choice C is azithromycin. Choice D is Bactrim and azithro. And E, no prophylaxis required. Also, if you don't know, you can say you were guessing or put a question mark by it, and we'll give everyone a chance to answer. Okay, so uh, everyone has chosen A, and A is correct. So good job. This patient's CD4 count is less than 200, and that's why prophylaxis for PJP is required, and Bactrim first is the preferred choice. Now, also, because the CD4 count is 90, we it's below 100. We also want to do prophylaxis for toxoplasmosis gondii. Now, Bactrim also provides prophylaxis for toxoplasmosis. So, Bactrim is choice A is correct. Very good. Because prophylaxis is required, we can cross out E. Can anyone tell me when B would be appropriate for prophylaxis? And it's not for HIV, it's for another condition that's frequently tested. So it's used in the treatment of TB, not prophylaxis. I'll give you another hint. It starts with an M. M as in Mary. M as in macaroon. And it's okay if you don't know, and it's okay if you guess. Nikki says malaria. It is not malaria. Rifampin is used in. Oh, we got someone else typing. We'll give them one more minute. Yeah, Genesis says Haemophilus. No, what they're What rifampin is used for prophylaxis is in close contacts of patients when meningitis is confirmed for Neisseria meningitidis. You see this in college age populations. Someone will test positive for meningitis, and if and it's a positive case or a confirmed case, you use rifampin for prophylaxis. Nice try, everyone. It is okay. Here's the space to not know something so you can go back and review and get it right when you take the test. Next question I have for you is choice C. When would choice C be appropriate? And I think actually if you're at choice C, you probably want to choose D. Once again, the question is for HIV prophylaxis, when are you going to use azithromycin? And you're probably going to be using Bactrim and azithromycin together. Correct. Good so far. If anyone knows the name of the condition as well. Good, very good. Very good, everyone. MAC, and when CD4 count is below 50. Good. Last question is what does HLA-B 5701 negative mean? What is the significance of HLA-B 5701 negative? All right. Nikki says Dapsone. Anyone else? Can't use abacavir. Okay, good. Melissa. Anyone else? So just to clarify, I didn't remember about Dapsone, but that's actually 1301, Nikki, and I don't think that's tested too much with uh there is something called Dapsone hypersensitivity syndrome, and before you think I'm super smart, which I am, I don't remember everything. I did look it up really quickly. So just to clarify, Dapsone is HLA-B 1301, and there is something called Dapsone hypersensitivity syndrome. But yes, going back to abacavir, suspicious bunch with the sound effects. If they test positive, you can't use abacavir. If they test negative for that HLA, you can use it. So good. Good job. Good job. All right, let's go on to the next question. Practice question two. Oh, before I go to practice question two, did anyone have any questions or concerns for this practice round? Any questions or concerns for the first one? Yes, Art asks, can I explain answer D? So answer D is Bactrim and the zithromycin, and you use that when the CD4 count is below 50 because that will cover PJP, that will cover toxoplasmosis, and that will cover MAC. Good question. Anyone else? You're welcome. All right. And if you think of a question later, feel free to send me a message. Happy to discuss with you that. So now let's look at practice question two. Same thing. I'll read it. Put your answer choices in at the end, and then we'll go over it. Ambisome or amphotericin B liposomal formulation is an IV agent used in the treatment of various fungal infections. Which of the following statements regarding ambisome is true? Select all that apply. So I would just like to remind you that when it select all that apply, it can be one of them, it can be all of them, and it can be anything in the middle. It's a true test of your knowledge. There's no real pattern. And I've not noticed a pattern in RX Prep or the past Naplex now cubics. So choice A, Ambisome 50 milligram vials must be reconstituted with sterile water for injection and then further diluted in dextrose. Choice B, Ambisome must be filtered using a 5 micron filter when injecting the reconstituted drug into the final diluent bag. Choice C, when administering Ambisome, the patient's IV line should be flushed with D5W after administering the drug. Choice D. Incidence of nephrotoxicity and infusion-related events with Ambisome are higher than with Fungazone, which is a deoxycholate formulation. Ah, yes. And then last, E. There are no recommended dose adjustments in renal or hepatic impairment for Ambisome administration. So whenever you're ready, excuse me, go ahead and put your answers in the chat. So far, right? Got four. Anyone else? So I've got five on here. Five students have responded. Good. So we know amphotericin B is an antifungal, and the mechanism of action is disruption of the fungal cell wall. The drug binds with ergosterol, and that leads to pores and leakage. Now, amphotericin B has significant toxicity, nephrotoxicity, nausea, vomiting, and fever and chills. We usually use it if there's severe or life-threatening invasive fungal infections, and if they also cannot tolerate voriconazole. So, A is correct. There are very specific instructions regarding the prep and admin, and it is something the Naplex tests on and something that you as a pharmacist need to be aware of. So it is only available in 50 milligram vials, excuse me, and you do need SWFI. Then it is further diluted in dextrose. If you use bacteriostatic water, sodium chloride, or other fluids, precipitation may occur. So A is correct. Good job, whoever chose A. Next, choice B is also a correct statement. It is supposed to be filtered through 5-micron filter, which is supplied with each vial. And this is to prevent a condition called microparticulate induced phlebitis. I'm just going to copy and put that in the chat. Okay. And so choice B is a true statement. D5W is the most common diluent, but it seems like you can also use D10 and D20. Art is asking, is it not a 1.2 micron filter? I have it is 5 micron filter that is supplied with each vial. And if you give me 1 second, I will double check. Give me some. Just a second. Filter. So I have 5 micron filter from multiple sources. The FDA, Gilead, and Stanford Med. So I'm not sure. This is liposomal. It's not a lipid medication. Maybe that's the confusion for the 1.2 micron. Uh, Art, Nikki, I'd make a note of it and go back and double check that. So C is also, answer choice B. The final product must also be protected from light. Next, we have answer choice C. C is also true. An IV line should always be flushed with D5W after administration of ambisome. If this is a pre-existing IV line, it should also be flushed before. So before and after. If it's a pre-existing, if it's a new IV, then flush after. Now, choice D is incorrect because the liposomal formulation or ambisome has a lower incidence of nephrotoxicity and infusion related events over fungazone, which is the deoxycholate formulation. So, uh, fungazone has a higher incidence of nephrotoxicity and infusion related events, making D an incorrect answer choice. Last, we have choice E. That is true. Ambisome can cause significant nephrotoxicity, however, it does not require any dose adjustments. For renal or hepatic insufficiency, if the patient is on traditional hemodialysis, you should give it after dialysis on those days. So that is ambisome. Once again, A, B, C, and E were correct answer choices. Anybody have any question or concerns about number 2? Oh, sorry, I didn't know the screen was paused. Yes, I can explain E again. Ambisome after administration can cause nephrotoxicity. However, if the patient has renal or hepatic insufficiency, you can still give it to them. I hope that helped. Did anyone else have any questions about number two? All right, let's go on to number three. DP is a 60-year-old female with a history of hypertension, hyperlipidemia, and stroke who is receiving induction with cytarabine and daunorubicin for acute myeloid leukemia. She has allergies to penicillin, rash, and aspirin, rash. Home meds include Plavix 75 milligrams PO daily, Lipitor 40 mg PO daily, and lisinopril 20 mg PO daily. Today, the patient has new onset shortness of breath, cough, and a positive galactomannan test. Calculated creatinine clearance this morning was 60 ml per minute. She is to be started on IV VFEN for presumed invasive aspergillosis with further workup pending. Which of the following is or are true about VFEN in this patient? Once again, select all that apply. Choice A, VFEN will inhibit the metabolism of Plavix, potentially increasing the patient's bleeding risk. B, VFEN will induce the metabolism of Lipitor, potentially decreasing the effectiveness of Lipitor. VFEN may cause QTC prolongation. VFEN may cause visual disturbances. And based on renal function, this patient should be given 50% of the usual VFEN dose. Mr. Turtle, welcome. This is the last practice question. Whenever you're ready, please put your answer choices in the chat. Once again, select all that apply. It could be one or it could be all or anything in between. And if you're not sure, that's okay too. Make your best guess. Okay. We'll wait for one more response. All right, very good. So the correct answers here are C and D. So good job, Autumn. Good job, Art. And let's talk about why. So the generic for VFEN is voriconazole, and it is the drug of choice for the treatment of invasive aspergillosis. And voriconazole inhibits CYP2C19 and 3A4. So clopidogrel or Plavix is activated by 2C19 because it is an inactive prodrug. And when voriconazole inhibits 2C19, less clopidogrel is converted to its active form. This increases the risk of arterial thrombotic events. So that makes A incorrect. It doesn't inhibit the metabolism of Plavix, it inhibits 2C19. Next is B, because it um, Lipitor or atorvastatin is metabolized by 3A4. So voriconazole increases the serum concentrations, increasing the risk of toxicity. So it is incorrect. Choice B. So C is correct because, like other antifungals, especially the azoles, voriconazole can cause QTC prolongation. There's two or three other drugs that can prolong QTC. Can anyone tell me any of them? Any that you remember? QTC prolongation? One, two, three, whatever you know is acceptable. All right, we have amiodarone, fluoroquinolone's good. All right, and we have the antiarrhythmics, good. Another one is Allegra, aka fexofenadine, which is an anti-allergy medication. Good. Next, we have choice D. D is also correct. And visual disturbances include blurriness and color changes. Once therapy is stopped, these visual changes are reversible. Last but not least, choice E is incorrect because voriconazole is cleared almost entirely by hepatic metabolism, so renal dose adjustment is not required. However, do keep in mind that IV voriconazole has an inactive ingredient called cyclodextrin, which can accumulate in patients with renal impairment. So just keep that in mind. You don't have to do dose adjustment, but if they do have renal impairment because of an inactive ingredient called cyclodextrin, just be careful about that. Sapphire asks, why is choice A incorrect again? Choice A is incorrect because voriconazole doesn't inhibit the metabolism of Plavix. It inhibits 2C19, which prevents the prodrug from being activated. So it does, so the second part is correct where it increases the bleeding risk, but the mechanism that the test question is asking is incorrect. You're welcome. All right. Anyone else have any questions or concerns about any information today for opportunistic infections, any of the practice questions, anything that I can help with? Nikki asked, can I explain answer B again? Yes. So answer B is incorrect because it doesn't induce the metabolism of Lipitor, it inhibits 3A4. So 3A4 is how Lipitor is metabolized. So if you're inhibiting 3A4, that means there's less breakdown or metabolism of Lipitor, and it'll increase the concentration of Lipitor. So theoretically, you have more Lipitor in your system. It's supposed to be more effective, but it also can increase the risk of toxicity. Basically, the first part is also incorrect. It doesn't induce the metabolism, it inhibits 3A4. All right, good. Anyone else have any questions or concerns for today? All right. Well, so that was opportunistic infections. If you do think of something later, feel free to send me a message. Thank you all for joining today. We'll end with another affirmation. You are on a journey to help yourselves make your lives better, as well as the patients that you come into contact with. Keep that as your focus. Try your best, and one day you will get the result that you are looking for. It was a pleasure being here this evening. Have a good evening, everyone. You're welcome.